substance use disorder, and the focus is going to be substances other than alcohol. Yes. So I am not giving a written study guide. I will give many hints about what's important in terms of what to focus on for the exam. So you listen up for that. So this is important. This is an important concept. So we listen to that. And I do have some aha slides at the end. I want to make sure that I do take some time to go over those. So it's a lot of content. We'll be going pretty quickly. At the end of class, Kara Moriarty, the lab coordinator, will be coming over. She has a very important announcement to make for you all as graduates regarding a resource that's going to be made available to you for NCLEX preparation. So make sure you stick around for that. Okay? All right. So substance use and addictive disorders. Many of you probably this semester and last semester and every semester you've been here, you've probably interacted with clients in whatever settings, whether it's maternity in the NICU, with a baby with, for example, withdrawal from narcotics, NAS babies, or in the acute care setting, somebody withdrawing from alcohol, or somebody who has an addiction to opioids or other substances. And even in areas like in the community setting, right? Many of you are at Relief that focuses on mental health. There's this connection with mental health and substance use disorder. If you're at Gosnell or Duffy, you're working directly with patients who are actively working on recovery. So it's something that you're going to be dealing with in just about every setting. We are in a position as nurses, right? We spend time with the patients. We develop caring and therapeutic relationships with them. We show we care, which is foundational for patients going through addiction, to help learn tools that they can to reach recovery. So that is the goal, that people who have addictions, and we're not talking just substances, we'll also be talking non-substances as well, but we are in an ideal position to work with these patients. How many of you personally know somebody who has an addiction? I can guess just about everybody, okay? So they might be a friend or it could be a spouse, it could be a parent, it could be yourself that struggled with addiction. The CDC in a 2020 study showed that 1 in 7 over age 12, I read that in age 12, that's really young, but this is a large study, it's self-reported having some type of substance use disorder in all sorts of practice settings. So it is something we're going to be coming in contact with. We need to make sure as nurses, for working with any, we talk about cultural competency, there are stigmas and biases that go along with working with patients in this population. If you close your eyes and you picture yourself, somebody with an addiction, what types of things come to mind? Somebody that has an addiction. If you close your eyes and you picture somebody with an addiction, how do they present? How do they look? A little louder. Yeah. Can you think of nodding off in public? So somebody that's nodding off in public, they don't care about their appearance. Undernourished, so their calories are not sound nutritional, they're more either liquid or other substances. Fidgety, so there might be, definitely restless. We're going to talk about the effects of different substances, and then we're going to talk about withdrawal of different substances. But we do hold normal biases and there are stigmas associated with those with an addiction. And then I want you to close your eyes and I want you to picture that person before the addiction, okay? So a normal, you know, apparently or possibly, you know, pretty normal person. It could be somebody who has had something happen in their life. We'll talk about the things that precipitate an addiction, but some of the things that happen are traumas in somebody's life or an injury, something out of their control, right? So having an awareness of your own biases is really, really important. So we're constantly doing self-inventories, especially when you find yourself getting a little hardened to those patients, right? Over and over again, if you're working in settings where you're working with these patients, you might become a little hardened, right? That patient comes in again, that patient takes up a lot of your time away from your other patients. You think you've made a difference with them, and then they come back. You know, it could be a day later, it could be a year later, it could be quite a bit later. So let's talk about the learning outcomes. The learning outcomes that are integral to the knowledge of this content. So these are our student learning outcomes. You're familiar with them. Safety, patient-centered care, professionalism, teamwork and collaboration, and evidence-based practice. So everything that we do is focused on these as graduates of a nursing program. These are the outcomes that we want you to know. As far as safety, the students and graduates, nurses, will demonstrate the ability to assess and manage safety risks for patients with substance use disorder, ensuring appropriate interventions to prevent harm due to withdrawal symptoms, overdose, or co-occurring mental health disorders. Keeping your patients safe is top priority, right? So we're constantly looking at that. What are protocols for safe administration of meds in these settings? The medications we're giving in these settings can harm the patient. Can you overdose or kill somebody with lorazepam? You can. So with other medications, it's really, really important that we are safe with medication. Also, other meds like methadone, buprenorphine, and naloxone and Narcan. Patient-centered care. If it's not patient-centered, it's not going to be near as helpful, right? You have to have that caring foundation. You have to have an individualized care plan. Make sure it's holistic, that you're looking at your patient and developing a plan of care for them specifically. Communication skills is critical for collaborative decision making. We're working with a lot of other practitioners in this area, from social workers to psychiatrists, other kind of medical teams. So really important to communicate effectively with that team, because it is a team approach. Professionalism. It's sometimes very easy to go from empathy to sympathy with these patients. You feel yourself, your heartstrings pull for these people, what they've been through, the difficulties they've been through. You have to maintain professional boundaries at all times, okay, and be aware of that. If you find yourself transitioning more to sympathy, you need to stay empathic. Professionalism, teamwork and collaboration, team-based approaches I mentioned, ensuring that treatment plans are comprehensive and patient-centered. And then everything is always evidence-based. If we don't have a sound scientific foundation for what we're doing, it's not going to be effective, right? We need to have evidence-based practice. So those are all important. All right. And then the more detail about this, we'll be looking at the role of addiction and substance-related disorder, as well as non-substance-related addictive disorders. We're going to identify prolonged effects of things like marijuana, stimulants, tobacco, hallucinogens, opioids, and inhalants. Strategies for developing that patient-centered, recovery-oriented therapeutic relationship. Talk about medication, a big part of what we do. And then how do we connect with these patients? How do we learn what motivates them? So things like motivational interviewing, harm reduction. If we can do anything, we do something called SPURT screening. You'll need to remember this: screening, brief intervention, and referral to treatment. SPURT. It's a reliable, valid assessment tool that we use in this setting. And there's a slide on it. Screening, brief intervention, and referral to treatment. So that brief intervention is in the referral to treatment has a focus on harm reduction behaviors, because these people with addictions either harm to themselves, harm to others, right? So they're out there driving. So you want to look at any of the harmful behaviors that they're exhibiting and ensure that they have resources and they know that this is not good. And always gearing toward recovery. So what is an addiction? What kinds of things qualify something as being an addiction? I'm addicted to something. Say it again. You continue to use it regardless of adverse effects. Good. Anything else? You're dependent on it. That's an important term. I have a video from somebody from Gospel that I'm just going to do an excerpt from it, but one of the things that the nurse practitioner states is that it's an attempt to solve internal problems with external solutions with negative consequences. It's an attempt to solve internal problems with external solutions with negative consequences. Okay? It's an attempt to solve internal problems with external solutions with negative consequences. There's often a trigger. Something sets somebody off. It could be walking by a home that they live in with their family member. It could be a date. One of my close friends, a physician years ago, every holiday she would do fine outside of the holiday season. And she would do that. Negative consequences include things like strained relationships, job loss, changes in brain and body, such as tolerance and illness. So let's talk about substance use disorder. So that involves a chemical, okay? Some type of chemical substance that leads to clinically significant impairment during a 12-month period. Non-substance related disorders. So these are behavioral or process addictions. And they include things like gambling, sexual activity, pornography, shopping, social media, internet gaming. You can probably food. You can probably think of others as well. So some of these substances that we're going to talk about include alcohol and cannabis, includes marijuana, hashish, THC, hallucinogens that include LSD and MDMA, PCP, inhalants such as glue, lighter fluid, gasoline, screen cleaners, and aerosols, opioids such as heroin, codeine, and there's a lot of prescription opioids we'll talk about, sedatives, hypnotics, and anxiolytics, stimulants such as amphetamines and cocaine, and then tobacco. So these are all substances that have the possibility for addiction.
If someone was like using one of these for 6 months, could you still diagnose them or would it have to be?
So DSM, you know how DSM states like they will put a time limit on something to get that diagnosis with under DSM-5. They suggest it has to be a 12-month period. Can somebody have an addiction in a 6-month period? Well, sure. Yeah, if they fall under that category. It's characterized by loss of control due to substance use or behavior, and the participation that continues despite problems and a tendency to relapse back into behavior. So we have these periods possibly where they are not using, they're not showing those addictive tendencies, and then they have a relapse and they back into behavior. Coping mechanism is one of the big ones that's important to know about is denial. And that can prevent the client from not being involved with the behavior. So there has to be some self-insight and acknowledgement, just like with alcohol, that they have a problem, they have an issue, and they need help to control it. Is an addiction curable? Can you cure somebody's addiction? No. So think about AA. They say, you never say, I was an alcoholic, I am an alcoholic, is what you would say. Because you're in recovery from that substance. And there's always a possibility for relapse. So I updated the data on this slide from last year. So this shows the extent of use of illicit substances in the United States. Okay. So what you're going to see is that it's just increased. So in 2017, these are statistics for 2017, about 15% of the population was using marijuana, 40.9 million. 2023 data that's increased to 61.8 million. It's now legalized, right? So we're going to see those numbers higher at the beginning of it. With cocaine, it's actually gone down 5.9 million to 5 million. Hallucinogens has increased from 5.1 million to 8.8 million. Methamphetamines from 1.6 to 2.6 million. And then heroin use has actually gone down. Statistic I heard just yesterday was that overdose deaths involving opioids as a substance decreased from an estimated 84,000 to 81,000. So there was a significant, unprecedented decrease in opioid deaths due to overdose. Can anybody think of why that might be? Narcan. Right? So a huge educational effort to get the antidote for opioids into the right hands, into homes where opioid abuse is occurring, and all different types of places. So education to the community, to the public, and use of naloxone and Narcan as a reversal agent. And we'll talk about that a little bit more. Students brought up that alcohol is a drug, and that's true. If you look up, is alcohol a drug? They'll say yes. I just want to say I'm not going to test on that, but just know that alcohol is the most widely used substance, and of all the drugs, marijuana is the most widely used substance. But alcohol continues to be the most widely used. And I will not be testing that, which is alcohol is more widely used even than marijuana. All right, so some terms that are important to understand. So addiction, we talked about. The use. And by use, it means either we are orally taking something, ingestion, smoking, sniffing it, or injecting it, and creating mind alteration. Abuse definition is when it is used, I'm taking that substance for the purpose of intoxication, for that intoxicating effect, or beyond the intended use. The term withdrawal is when you no longer use that substance and your body responds with symptoms. And the process for safe withdrawal is detox, right? So your patient going to detox, or somebody's detoxing in their home with support, right? So detoxification is the process in place for safe withdrawal. When somebody does have a recurrence of disorder, it's called a relapse. All right. Do you think that substance use disorder is genetic? Are there some genetic predispositions, would you say? Yes, there are. There is no one specific marker, like I can't draw my blood and say I have a predisposition to alcoholism or other disorders. So there's no one specific marker for addictive disorders, but the more risk factors, the higher likelihood you are to develop. Those who have biological relatives with substance use disorder are at increased risk. So for example, my brother-in-law, his father was an alcoholic, so he has chosen never to drink alcohol because he knows he's got that predisposition, okay? Drug use can also negatively affect egg and sperm health, okay? So it can lead to some reproductive issues. Psychosocial components, there are certain things that increase our risk, okay? How we handle stress, our temperament, feelings about ourselves, so those with lower self-esteem. Those who have less of an internal focus or locus of control, we talk about this when we're teaching patients. Like, do you feel like you have any control over your health, or is it like random? Like it's random that you get cancer, it's random that you're going to get heart disease. Do you feel like you have a locus of control internally or externally? Also, our relationships with parental and family relationships can increase our risk. There's certain cultures where substance use within the family setting is not a big deal. Okay? You have the cool mom who wants their teenagers to allow alcohol in the home, right? Another thing would be peer pressure. So those who succumb more to peer pressure are more likely to engage in illicit substances because they have difficulty saying no. There are certain professions where there is an increased risk of substance use disorder. Do you think the profession that you're about to go into might be on that list? Yeah. And why is that? Has stress. Do you have access? You do. You get them from restricted. You can go out wherever you want. Long hours. Do you have a lot of responsibility on your shoulders? You have people's lives in your hand that you potentially to harm people. Right? So there's a lot of stress that you deal with every day. Okay. So all of those things together do place the nursing profession at increased risk for substance use. We'll talk about mandated reporting for that. We'll talk about treatment for that.
This is Susan.
Addiction.
Susan loves to bike. While out for a ride, she falls and breaks her arm. Special cells called neurons send the signal through the spinal cord to the brain, which interprets the signal as pain. Susan understands that pain means she needs to go to the hospital, and her body is equipped for survival, helping her not to panic so she can seek help. Many of her neurons are covered in proteins called opioid receptors. These receptors act like a brake to slow down the neuron's ability to send pain signals. When injured, the body releases natural painkillers called endorphins. Like a key in a lock, endorphins activate opioid receptors, slowing down the pain signal and preventing a panic. Susan gets treated for the broken bone, but 3 months later, her arm still hurts. And now that pain is making her feel depressed and anxious. So her doctor prescribes an opioid painkiller. There are many different opioids, but they all share a chemical similarity to our own endorphins. This allows them to bind to the same opioid receptors and stop pain signals. But that's not all they do. Deep inside Susan's brain is a region called the ventral tegmental area, or VTA for short. The VTA is full of neurons that produce a chemical called dopamine. When something good happens, dopamine is released, giving Susan a feeling of pleasure. This helps teach her brain to keep seeking out good things. To keep dopamine neurons in check, inhibitory neurons keep the brakes on until something good comes along. Just like the pain neuron, these neurons are covered in opioid receptors. When Susan takes the painkiller prescribed by her doctor, the opioid receptors turn off the inhibitory neurons and release the brake on the dopamine neurons. The rush of dopamine temporarily eliminates Susan's depression and anxiety, and she feels relief, calmness, and even euphoria. As Susan continues to take the painkillers, her brain responds by trying to regain its balance. Her inhibitory neurons work extra hard, even when the opioid receptors are activated, and it becomes harder and harder for her dopamine neurons to release dopamine. Susan finds that she needs to increase her dose of painkillers in order to feel comfortable. This is called tolerance. Eventually, Susan's pills run out. Inhibitory neurons that had been working overtime are let loose, clamping down on those dopamine neurons and shutting them off almost completely. Now, not only is Susan in pain, but the depression and anxiety come back. On top of that, Susan feels ravaged by an inescapable physical sickness far worse than any flu. Susan's body is going through withdrawal. Most people who take opioids for a long time tend to experience some withdrawal, but they can still stop taking the pills and return to normal. But for people like Susan, it's not so easy. Her genetics and the environment she grew up in put her at a higher risk for addiction. Her withdrawal symptoms aren't just unpleasant, they're unbearable. Susan thinks the only way to feel normal is to find more opioids. And this is how the cycle of opioid addiction emerges, driven by a brain trying to regain its balance. But there is hope for Susan. Though the road to recovery can be challenging and there may be setbacks, treatment can retrain Susan's brain. With the help of medication and therapy, Susan finds pleasure in her life once again.
Any thoughts on that? Kind of makes you see like how quickly, it can take one injury. My daughters, they all went skiing last weekend, and somebody had a major back injury. Now they're dealing with what has become chronic pain for them. So that person is like higher risk for, turning to substances to help with that. So always thinking about these types of things, and then having a background as well. So the a little bit of genetics, a little bit of environment. Things can change pretty quickly for somebody, unfortunately. So let's talk some more about some of the epidemiology. So this is from self-reports. This is from 2019, 7.9% of 8th graders, 18.4% of 10th graders, And by senior year of high school, about 29.3% reported getting drunk in the past month. Less than 20% of high school seniors reported binge drinking. 1.3% of 8th graders, 4.8% of 10th graders, and 6.4% were using marijuana daily. So that's daily. There's been a decrease in the amount of cigarette smoking with teens, but vaping, on the other hand, has continued to increase. And I heard some statistics because there hasn't been a whole lot of evidence out yet about the effects of vaping with nicotine, and they're saying that it is, so the studies that are beginning to come out are that it can be very, very harmful. And it's important just to be aware of that and continue to watch the studies. And then it's important to be aware of, as nurses, issues regarding diversity and disparity. So youth that identified as sexual minorities will probably have a higher substance use. They experience more violence, victimization, or at higher risk for suicide. So it's important to be aware of that, to be aware of racial and ethnic disparities as well. Those are disproportionately incarcerated for drug crimes and placed in facilities that have insufficient substance abuse treatment and follow-up. So it's important to be aware of disparities and have input into what you can do, either at the individual level, community level, at a public level, to help address these issues. Often, substance use can go right along with other mental health issues. Okay? So there are certain mental disorders that commonly co-occur with addiction, things like anxiety and mood disorders, schizophrenia, bipolar, conduct disorders, and major depression can commonly occur with addiction. And then patients who are being treated for mental disorders are also often misuse things like alcohol, tobacco, opioid stimulants, marijuana, hallucinogens, and prescription drugs. So nurses should be aware that patients who abuse substances might also have things like anxiety, mood, personality disorders, and psychosis. So what's important is screening. So if you have a patient with a mental health disorder, you are screening them for substance use disorders, and then vice versa. If you have somebody with a substance use disorder, you're screening them for any mental health issues, because it's important to address both, correct? We've already kind of talked about family responses. It can have devastating effects on families and the community. It can affect your job. It can affect relationships. Often, persons who recover from substance abuse find that they must distance themselves from families that are actively using substances, right? So that can be very, very difficult. And it might be the most difficult piece, is having to distance yourself from old friendships that were not adaptable. So that's an important thing to remember. Not having good coping skills, not having learned healthy coping mechanisms also can influence. So this is an example of a screening tool that's valid and reliable, evidence-based. It's called a DASS. If you scan that, it'll take you to the actual screening tool. It's a 10-item questionnaire, very similar to like the audit thing we talked about with alcohol, looking at the frequency of substances in the past year, monthly, weekly, or daily. Have you injected drugs in the last instance? Have you been to a treatment facility? And so you score yourself, and that score identifies the risk for drug abuse and helps identify, then you can then make referrals to treatment. So this is one example. All right, so let's start talking about some of the substances. The first ones we're going to talk about fall under the category of sedatives, hypnotics, and anxiolytics. So these are things that are that decrease things like anxiety. They have a sedative effect. Okay? So those are the intended effects. An example would be benzodiazepine, such as lorazepam or diazepam, so all that PAMs. Also barbiturates, such as pentobarbital. And then club drugs, such as flunitrazepam, which is the date rape drug, is either orally or it can be injected. So this causes drowsiness, sedation. It can cause agitation and slurred speech, uncoordinated motor activity, nystagmus, disorientation, nausea, and vomiting. These, because they are sedatives, they're going to cause respiratory depression, right? And decrease level of consciousness. So those things together, if used in excess, obviously can be fatal.
Just say that one last thing again, I was writing.
So if used in excess, things like respiratory depression and decreased level of consciousness can potentially be fatal. If you were to suddenly stop these drugs after taking them repeatedly, you can have withdrawal, and symptoms of withdrawal would include anxiety, insomnia, diaphoresis, hypertension, psychosis, tremor, nausea, vomiting, hallucinations, psychomotor agitation, and possibly seizures. So I'm not going to go into detail requiring you to know all of those. But the most important thing with these drugs are to be aware of their effect, and then what would you do with overdose with it? So if you have somebody, there is, we'll talk about a antidote for these. Stimulants, the effects include euphoria, increased wakefulness, perception of diminished need for food and sleep. They can cause psychosis and psychomotor agitation. So stimulants are, so let's say somebody's working long hours and they, you hear this with movie stars, right? So they're having to work, I think about Judy Garland, I think of young people, they get hooked on stimulants. They need stimulants to get all their work hours in, and then they need sedatives to sleep at night, right? So they end up on this cycle of taking stimulants and depressants, right? In order to get in their work and to sleep. So stimulants are going to increase their productivity, and they're going to be euphoric and alert. Hallucinogens cause misperception, right? So you think of anything that is going to enhance your senses. Y'all know what a hallucination is, and a delusion. It can cause mood swings as well. So, the effects of cannabis, the intended effects are euphoria, feeling relaxed, sedated, and cause hallucinations. It can be used, a lot of cancer patients who are undergoing chemotherapy who have nausea, intractable nausea, will rely on cannabis. And for management of chronic pain. Okay. I know it's used for people with seizure disorders as well. So there are some really important medical uses of cannabis. Effects can depend on the strain or the dosing. And we're gonna talk in a minute of how the dosing has changed significantly over the last years. It's much more potent. So effects of intoxication with chronic use, there's an increased risk of lung cancer and respiratory effects, and problems with performance of daily activities. We hear about, the kids, the teenagers using cannabis chronically, and they lose motivation. They're not interested in school anymore. They have these personality changes where they just have no motivation to do anything. High doses can cause paranoia, increased appetite, dry mouth, tachycardia, and then just to know too, it can be used medically for that purpose. For somebody with a wasting disorder, such as cancer, it will help increase appetite. It can impair your motor skills for 8 to 12 hours, so it can affect driving and use of machinery. And if stopped suddenly, somebody's using it chronically, and they stop it suddenly, they're going to see irritability, they can have aggression, anxiety, difficulty sleeping, loss of appetite, restlessness, depressed mood, abdominal pain, tremors, diarrhea, fever, and headache. I do want to bring up something important to remember, and I see this in the ED, is something called marijuana-induced hyperemesis syndrome. Anybody heard of that? So, yes, you heard it. So patients come into the ED, they are daily users of marijuana, and they have had intractable nausea, vomiting, and significant weight loss as a result of this hyperemesis that can occur. So important to remember that marijuana can cause induced hyperemesis. Hyperemesis, is that what brought them into the hospital? Yeah, typically they require IV fluids, and it's, what I've seen the, the providers sit down and say, hey, the only thing that's going to help us is stopping marijuana use. So they have to be motivated to do that, otherwise we see them return. But it's pretty miserable. Chronic use in adolescents has been linked to a decline in IQ that may not recover with cessation. And it's also in adolescents associated with an increased risk for later psychotic disorders in adulthood. And marijuana use is linked to earlier onset of psychosis in those who are at risk for schizophrenia. And I have seen that. I mentioned there's changes in the potency of marijuana over the years. So in the 1990s, THC content within marijuana was 3.8%. It is now 12.2%. So it's much more potent. Average MJ extract has THC levels at greater than 50%. It's the THC that is the component within marijuana that's responsible for that euphoria and intoxication. So that's obviously going to increase addictive tendencies if it's a stronger strain.
Basically saying marijuana is actually completely unregulated in the sense that they're like, oh, this is this type of strain with this much THC, but it's all predictions because all the plants are so crossbred.
We don't know where it's coming from.
Yeah, I was very, but it was a good night. I don't know.
And now we worry about it, things like being laced with fentanyl or that happens in patients overdose. Sure. that. All right, opioids, okay? So opioid addiction is a crisis in this country. So opioids and morphine derivatives. So that includes things like heroin, considered an opioid. Fentanyl is a type of opioid. And then we have our prescription opioids, right? So we have morphine, we have oxycodone, we have Vicodin, we have methadone. These are all, so heroin is considered Schedule 1, and these others that I just mentioned, fentanyl, morphine, Vicodin, oxycodone, and methadone are all Schedule 2. They're all scheduled 2 except for heroin, it's Schedule 1. Mhm. And then there are prescriptions such as methadone and buprenorphine that are opioids that are used in opioid management or treatment plans. Okay? The patient must have stopped taking opioids, this is important, for 12 to 24 hours prior to starting on these treatment plans. Okay, so remember that, 12 to 24 hours. So
How do
this,
you, within 12 to 24 hours, you can do after, like, maybe,
yeah. 12 to 24 hours off of the opioids before starting on that. So at this point, I'd like to go to that Gosnold. They are obviously experts in this area, to this video, and then we'll come back to the slides. How do you want to, let's take a 5-minute break while I pull this out. I can tell you that I have a technical problem, so we'll take a quick break. Listen to it and.
It just really gets to show you what, how uncomfortable they feel pain relief, everything kind of slows down, they get constipated. So now when they're withdrawing, they're having insomnia, they're kind of restless, they feel pain, and what normally might feel like a special to anybody else, huge amount of pain from someone's huge arm performance. So their sensation anxiety, otherwise mild anxiety, GI upset, anorexia, loss of appetite, headache, diaphragm, palpitation, fatigue, autonomic disabilities, and tachycardia, hypertension.
So right now, she's talking about alcohol withdrawal, she starts with the opiate withdrawal in a second.
Withdrawal of alcohol,
And then she's gonna go into opioid.
as well as alcoholic acidosis, and urinary tremors. There's a difference between the two, because of alcohol and death. I'll move to this. So we use clinically validated tools in order to assess somebody's level of withdrawal. It helps us to kind of conceptualize and combine subjective and objective measures so that we can actually have a quantitative, a number to put to how severe that withdrawal is. It allows us to determine if somebody's in withdrawal, and it allows us to determine if the treatment's working. So for alcohol, we use the COS scoring, and for opiates, we use the COWS scoring. Another video. But this video is going to talk about, what do we have for tonight? So this video is going to talk about alcohol withdrawal and why I'm so concerned about it. Like I said, alcohol withdrawal is at risk for seizures. Some patient has a seizure and fall. Offensive, mental fever, really kind of like flu-like symptoms. But as the opioid withdrawal progresses, they start to experience diarrhea, which is severe, stomach cramping, depression, and drug cravings, especially if the withdrawal is not adequately treated. And it says here that the peak is within 72 hours, it usually lasts a week or so. It really depends on the opiate. Now with fentanyl out there, it's so long lasting that we're really seeing patients hit their peak in about like 5 days a week. So it really does take a longer amount of time. It depends on the person, it depends how much you're using, it depends on the drug. So this timeline is kind of more, a little bit outdated, I would say. So some of the treatments. So for alcohol withdrawal, we have a couple of different options. We have benzodiazepines, including Librium and Ativan. So the way that benzodiazepines work is that they stimulate the GABA receptors, the inhibitory neurotransmitters. So as you know, when we start drinking, our GABA levels go up. When we stop, we come back, those levels dramatically drop. So this is to prevent that dramatic dropping. And it's going to help prevent seizures. It's to make people feel, anxiolytic, so they're going to feel more relaxed. They typically feel steady on their feet. I call it the active legs. So that's typically how they're feeling when they're on a benzodiazepine. The way that barbiturates work, so medications like phenobarbital for alcohol withdrawal, it works the same way on the GABA receptors, but it also has glutamate activity additionally. So glutamate are excitatory neurotransmitters. Those levels dramatically rise when we are withdrawing alcohol. And that dramatic rise is what's going to cause us to have seizures, psychomotor activity, hallucinations, and so in order to kind of prevent that, especially the seizure activity, we want to make sure that we're slowly increasing the glutamate levels back to the normal level. So phenobarbital or barbiturates allow us to do that. Typically, benzodiazepines are first line for patients, but if they've ever had a seizure, we'll typically see them on phenobarbital instead. For opiate withdrawal, we have a couple of different options. We have agonists. Have you guys had a pharmacology course yet? Yeah, okay. So agonist, as you might remember, binds to the receptor, increases a similar response. So we have methanol, which is a full agonist. It is an opiate. It works on the opioid receptor. So that's something that they can use in order to taper from opiates, or they can use it as medication-assisted treatment beyond it long-term. Buprenorphine is a partial agonist that preferentially binds to the opioid receptors and is stronger than other opiates. So we also again use this for detoxification or medication-assisted treatment. Because it is so strongly partially binds to the opioid receptors, you don't really start buprenorphine until they like insignificant withdrawal already. Otherwise, you're going to make them have precipitated withdrawal, which is when they feel all the symptoms of withdrawal at once. That is a very uncomfortable experience. patients are detoxing from opiates comfortable and at a comfortable level, when we are in treatment, our tolerance decreases. So if the patient's feeling uncomfortable, they want to leave, they want to go use, that same level that they got of tossed or fixed before, if they were used to using their gram a day for treatment, and they go out and they use gram a day again, that could cause overdose because their body has reduced tolerance from treatment. So that's why we want to make sure that we're keeping patients at a comfortable level when they're staying in their treatment. We have antagonist treatments. Naltrexone is relapse prevention, and naloxone is used for overdose. Suboxone, which you may have heard of, little tablet or little pill, is a combination of both buprenorphine and naltrexone. This is just a little visual about how agonists and antagonists work. There's also, I'm not going to go through all these slides, I don't think it's pertinent necessarily, there's also other pharmacological things that we can do to make patients more comfortable, comfort medications for anxiety, comfort medications for GI distress, that kind of thing, that can make patients more comfortable while they're detoxing.
And do you know that these medications like the
And then I just want to touch back on it, it's huge passion and understanding, is just making sure that you're aware of the whole biases. If you're going to be working with the population or be in a setting where you are working with somebody with addiction, it's just be mindful, and take a little self-inventory, and just remember that everybody just needs to feel better. This is kind of coming at it with an empathetic approach, it's just hugely important. And again, for the sake of time, I'm not going to play this video, but if you can upload it, I guess.
So that video is listed under the little module for this content. I encourage you to watch it. It's about empathy. Okay, so we'll see if I can get my slides back. Oh, there we go. So, so this is, you know how you have the CWA scale for alcohol withdrawal? So this is the COW scale, clinical opioid withdrawal scale. So you may be using this scale if somebody's actively withdrawing from opioids, okay? So, the things that you're going to see on it include resting heart rate, okay? So this is a score system as well. There's a list down here of, mild, moderate versus moderately severe to severe withdrawal. So depending on where they're at, so heart rate greater than 120, are they sweating? Okay, diaphoresis, also on the CWA scale. Restlessness, are they unable to sit still for more than a few seconds? We'll get a score of 5. Pupil size, so if their pupils are dilated and only the rim of the iris is visible, that would be a 5. Bone or joint aches, runny nose or tearing. GI upset, so this is not on the CWA scale. The runny nose is not on the CWA scale. The bone or joint aches is not CWA. So you see the differences between the opioid withdrawal and the alcohol. Tremor is on both, right? So gross tremor or muscle twitching. Yawning, so yawning several times per minute can be a sign of opioid withdrawal. Anxiety is on both. Piloerection, where you've got, goosebumps and your hair standing straight out, that is on here as well. So you get a total score, and more than 36 would be considered severe withdrawal. And just want to point out, I brought this up in the alcohol lecture that we did. This most often, the opioid withdrawal, isn't going to kill you. Like alcohol withdrawal, you can go into what's the term of the severe alcohol withdrawal that can be potentially fatal. Things with two words. Delirium tremens, DTs. So you want to prevent DTs in your alcohol withdrawal patients, right? That can be potentially fatal. Okay. Opioid withdrawal is not potentially fatal. So typically it peaks in 72 hours, and then fentanyl can last quite a bit longer if it's running fentanyl, another opioid. All right, so we are going to, I want to talk briefly about nicotine as an addictive substance. This is probably, the most common addictive substance that you're going to see. And you can make a difference in it with your patients. Slide 26. Pardon? There's not a nicotine withdrawal scale. So the COW scale, I don't have any questions on it, but just be aware that there is a withdrawal scale for opioids. All right. So nicotine. Nicotine affects the nicotinic receptors in the brain, the carotid bodies, the aortic arch, and the central nervous system. Tobacco can be inhaled with cigarettes, cigars, or smokeless, and is chewed or snuffed. There are many harmful substances at toxic levels that can have long-term effects and contribute to all our major disorders like hypertension, stroke, coronary artery disease, cancer, gum disease, dental disease. Withdrawal symptoms, also called abstinence syndrome, can include irritability and cravings for the nicotine, nervousness, restlessness, anxiety, insomnia, increased appetite, difficulty concentrating, anger, and a depressed mood. When you're screening your patients, part of your admission, just irritability, cravings, weight gain, because now you're eating more, nervousness, anxiety, insomnia, difficulty concentrating, depression.
And you said it's also called what?
Also known as abstinence syndrome. And it stimulates central, peripheral, and our autonomic nervous systems. And there's an increased release of norepinephrine or acetylcholine. To be successful, evidence has shown that it requires more than one type of intervention. Okay, so a multi-process intervention. So when your patient comes in, they should all be screened and asked, are you a smoker, past smoker, present smoker, how much do you smoke? And then once I have time, I'll talk to my patients. That's one area that I always touch on for teaching at discharge or during their hospitalization. I'm at the bedside with them, and maybe preparing a med or something, or they're on a nicotine patch. We'll talk about the nicotine patch as being a method of treatment that they can then continue on when they are discharged. So the nicotine patch is replacing nicotine transdermally. There's also gum. So there's patch, transdermal patch, as well as gum. And you are preventing those withdrawal symptoms by giving them some dose of nicotine through this patch. Okay. There are lozenges, there's a nasal spray, there's an inhalant as well. So there are many, many routes of the nicotine patch, nicotine replacement. Often we are doing transdermal. It goes on in the AM, should clean the skin. And it should go on clean, dry skin. And then we remove it before bed. So it's on for about a total of 16 hours. Yeah, patients can complain of nightmares from the nicotine patch if they wear it overnight. If they're going for an MRI, it should be removed. Okay? When it's removed, you fold it over in half, and it goes in. It doesn't go in the trash. It goes into the dispensing thing in your bedroom for with a patch, and they have a child or a baby at home, and that child or baby, sucks on their arm, and they get a patch, ingest the patch, that could be very, very harmful. So make sure that they're aware that they should not leave it out, and that can occur. Gum should be chewed slowly over 30 minutes. And you'll notice that they can have that hourly, okay? So you can pull that hourly, and they can have that in addition to the transdermal patch. I would make sure that order is in place, of course. And then with the lozengers, they should not have more than 6 months of lozenger with a max of 20 per day. And you should not have food or drink for 15 minutes if you're taking the gum or the lozenge. Right.
Yeah.
With the nasal spray, there should be 1 spray in each nostril, and that's equivalent to nicotine of about 1 cigarette. You do see a rapid rise of nicotine in the blood after the spray. And it does contain menthol, which has a similar sensation in the back of the mouth as smoke. So the nasal spray might be something that your patient is interested in. It should avoid if they have asthma or chronic sinusitis. E-cigarettes are discouraged as the dose of nicotine is unpredictable and there's little data on the safety and efficacy. There is an antidepressant that is used for addictions as well, and that's Wellbutrin is the trade name, or bupropion is the generic or official name. Pardon? It does. All right. I'll often ask the patient, have you ever quit smoking? And if so, what worked for you in the past? So they should not only go home with some type of nicotine replacement, but they should have a plan in place for follow-up and some type of behavioral resources such as support groups. Kick Butts, it was a support group they used to have. I have not seen it actually since COVID. I'm not sure if it's still available. But respiratory therapy is consult. Somebody is a smoker, and they are responsible to introduce nicotine switching with the patient, but the nurse being at the bedside is often the one that's doing that. Okay, we're going to this slide's on emerging drugs and trends, but we're going to go to other non-substance related addictive disorders. So this includes things like gambling, internet addiction, social media addictions, sex addictions that include pornography, sex addiction, food addiction. So there's a table in blue that lists all the different non-substance related addictions. So these are characterized by risky use, urges, cravings, and highs that make them similar to substance intoxication and dependence. We can see the same neurocircuitry involved in that reward motivation as substance use disorders. So often they talk about patients with addictive disorders, whether it's substance or non-substances, you're chasing that dopamine high, right? So you keep wanting more. That dopamine rush that you feel, whether it's with that reward center in your brain is stimulated. These are known as behavioral addictions. So when the disorder, when the behavior takes over the individual's life and creates negative consequences, that's when it becomes considered an addiction. The person spending excessive amounts of time seeking behavior, continuing to engage in the behavior despite negative outcomes and consequences, gambling addictions. So they can lose their entire savings, their home, prioritizing the behavior over other activities and increased risk taking in order to engage in and hide the behavior. So when you have a patient who is in your care, one thing you want to know is when did they last use, just like with alcohol, right? So are they in withdrawal? Are they going to be withdrawing? What is important to monitor? So knowing using the scale, making sure that there is a withdrawal scale in place if they are withdrawing, like for example, from opioids. You're gonna, as far as the therapeutic relationship, encourage honest expression of feelings. I know they used to say with alcohol, you would triple the amount that they report that they're ingesting. I think, since we've changed the treatment, patients want treatment. They often are very honest about what they're taking. And I think as we have evidence-based treatments in place, that they are honest in how much they're actually using. Listen to what they're really saying, express caring for the individual. At the same time, holding the individual responsible for their behavior. Provide fair and consistent consequences for negative behavior. Talk about specific objectionable actions, especially things like that are potentially harm other people, right? Driving other dangerous, especially. Do not compromise your own values or nursing practice. Communicate your treatment plan. And then have self-awareness instead of your own response. We do want to be sure that we do not feed into the stigma that surrounds addiction. And you can hear things like in report, the way a nurse might describe a patient. You want to make sure you're using appropriate language for the addictions. Another thing I noticed in the ED, I'll see that some might think that perhaps if I don't make this person comfortable, don't offer a pillow, that I don't offer food for a long time, or I don't give them a blanket, they're less likely to come back the next time. Do you think that's going to influence somebody's interest in returning if they are withdrawing or need help, need detox? I have seen that. I've never really understood that. Offering food, pillow, making sure they are comfortable, they're feeling bad enough going through withdrawal, right? So you do want to provide the, what is Maslow's hierarchy of needs, right? You have to meet physical needs first for trust to develop, right? So if you're not meeting those physical needs with comfort and food and drink, you're not setting the foundation for a good nurse-therapeutic relationship. All right, SPURT. So make sure you understand what the S stands for. It's screening. The BI is brief intervention and referral to treatment. And the goal is to reduce risky behaviors, reduce risky substance use before people become dependent and addicted. So this is a screening tool. If you know they're actively withdrawing, obviously you're not screening them. But let's say somebody comes in your ED and they report or you suspect cocaine use or heroin use or alcohol use, some type of substance use. You're going to use this screening tool. Okay? And then they recommend a brief intervention. And that brief intervention could include something like, it can include motivational interviewing. It can include, discussion of their intent to make some changes right now. Okay, so it can include education on those high-risk behaviors. Okay, and should they be motivated to make a change, it might be that you now are going to refer them to treatment. Okay, so the social worker is typically the person that's going to put this in place, set up outpatient or perhaps inpatient treatment. Okay, so it's for screening, and it's to address risky behaviors first off, and then to refer them into treatment, and with the goal of hoping to prevent them from becoming further involved in that addiction.
Can you just talk about the brief intervention? Again, I was writing in.
Yeah, so the intervention is it would include like motivational interviewing, finding out where they are. Like, are you ready to take a step here and go to a detox facility? They might in the moment say yes, but then once you make the referral, they're going to say no. I mean, it's kind of to see where they're at and to address risky behaviors. Okay, so safety is key right here. Are they driving while they're under the influence? Are they taking care of children in the home? Looking at those risky, high-risk behaviors. Are they using dirty needles to shoot heroin? Right? So you're looking at those risky behaviors. So that's called the brief intervention. This next slide talks about other interventions. It's not associated with SPURT, but these are treatment interventions. So if you do refer them and they do go into a treatment, there can be, often combinations of things like cognitive behavioral intervention. Teaching them about adaptive coping skills, looking at maladaptive coping skills and how it's affected their life. Group interventions, individual therapy, family therapy, harm reduction strategies, and then peer support, still health service. All right, we're going to talk about medical dependency and professional nursing. So this is covered in the board, it's important to be aware of this. If you're working with somebody who you're worried about, who might be you question if they're diverting medication, signs of impairment, or if you yourself are struggling with this, what you can do. So risk factors exist, such as access. We talked about this, availability of drugs, training in the administration and injection of drugs, and familiarity with and the frequency of administering drugs. So we talked about all the things that can increase the risk as nurses, with the hours, the stress, the responsibility. Things that can prevent somebody from self-reporting that they have a problem. They might fear loss of their license. They might be reluctant to seek help. So typically, it's determined by state, the reporting laws, but mandatory reporting requires any nurse who directly observes another nurse engaged in the practice of nursing while impaired by substance abuse or diverting controlled substances to report that nurse in Massachusetts to the Massachusetts Board of Registration. So that is within the state of Massachusetts. So we directly observe, right? So you might have a question that's something like this. Let's say you are working with a nurse who you suspect patients who are under the influence of a substance while at work. You see them going into the bathroom for long periods of time. You notice that they have some changes in their LOC. And what would you do? What would be important to do?
It's your charge.
Yeah, so you're gonna go to the supervisor or your clinical leader or whoever, and you're gonna report it. You're not gonna become your own little investigator and try to figure it out, and, you're not gonna confront them and say, hey, are you using drugs? You could put yourself in a bad situation like that, right? So you're always gonna, report it to your boss, your manager, so that they can investigate it. And just so you're aware, treatment, nurses typically do not lose their license if they report that they have an addiction or a problem. They are offered treatment in return to nursing, and of course, have to show responsibility, and you have to show that you've been compliant, of course, and comply with any requests for things like drug testing. About 10% of nurses, we have addiction problems. 11% of pharmacists, the person that are filling your patient's prescriptions, and 19% of dentists. So as many as 100,000 medical professionals have a substance or alcohol abuse problem in any given year. These are signs of chemical dependency. Somebody might have some inappropriate behaviors at work, some slurred speech, non-compliance with acceptable policies and procedures, deteriorating appearance of job performance, sloppy, illegible charting, errors in charting, alcohol under breath, poor judgment, lying, covering things up, high achievement, volunteering for overtime or extra duties, so they have that access, right? Onset after prescription, after surgery, that'd be a high risk time. So it might, similar to the patient on the bike who broke the arm, it can, somebody might require surgery related to that prescription for that opioid, and now they've got an addiction, family history. So the goal for all is that they reach what we call recovery. It is a journey over a lifetime. It involves changes in lifestyle, often new relationships. Short-term outcomes can be evaluated within the treatment setting, and long-term outcomes are established and evaluated by the patient, who often continues to use professional and non-professional support as needed. So it is road to recovery is a lifelong process, and then it may involve saying goodbye to those who are not good for you, or are using you, or not support your efforts to get clean. All right. So we are going to, what time is it now? Okay, good. So we're going to go to AHA slides.
Professor, I have a question.
Yes.
Just back to when you were saying that is addiction curable, right? You said that? You had said about addiction being curable or not. You asked that, is addiction curable? Can you just explain that a little bit? Because We are trying to help the patient, right? So what would you say, yes or no? I think you said no.
Right, so, let's look at it this way, is addiction habitual? Would you say is it habit forming? Is addiction, have some emotional aspects tied to it? Yeah. If I were to ask you, can you cure it? So let's say somebody's been, sober, free of substances for 20 years. And you ask them, are you an alcoholic? They're gonna say yes. So they're in recovery, they've been sober for 20 years. But, if that diagnosis, that medical diagnosis is always a part of that, right? So it's manageable, but it's not curable.
Thank you.
So you can successfully manage it for your lifetime.
Thank you. I don't know if that was.
Anything on the exam about like genetic relation to addiction? And I'm only asking that because you had originally said
There's no genetic marker,
there's no
but
genetic marker.
there is a known predisposition. So no, and I won't be asking. Okay. Yeah, yeah. What slide is that? Is there one there?
It's 5 to 20. But this is the one that was here. Updated next slide. Exactly like that.
So there is an incredible video that was summarized that we need to know about our. Okay, this naloxone saves lives. So for antidote for opioids is naloxone or Narcan. And it is would it be an agonist or an antagonist? It's going to block the opioid receptor. Okay? So it's an antagonist. It can be given IM, sub-Q IV, or by inhalation. So you can see all the different routes. Here's a nasal spray, an injection. The antidote for benzodiazepines is flumazenil. It's a competitive benzodiazepine receptor antagonist. Reverses sedative effects and toxicity is given IV. I've never seen this given. Has anybody seen this done? That is the generic version. I'm not sure. So I'm going to have you watch this video. Okay, it is important that you do watch it. Kara is here as well. So what I'd like to do, I'd like to go through my AHA slides and then I'm going to have her speak to you after that. But if you watch this video on slide 20, the use of that, it's an excellent video and it will, like I said, really everything you need to know.
Untook the
code either.
Yeah. Okay, there's your code. While you're logging in there, one of the things with Narcan that's really important, is the assess restorations. And, so the patient might present, for example, that they haven't had an opioid overdose with 10 pupils, and a respiratory rate, less than 10, it might be much less than that, and then, their arousal is going to be affected. So, the priority, more than anything else, is going to be administering the naloxone. This is the route that you're giving it. An injection or a IV, or inhalation. That is going to be the key. All right, so we are going to go ahead and start. Okay. Yeah, be quick. All right. Is addiction curative? No. It's true, we got that wrong, make sure you know that. It does have an emotional component, it is a medical illness, and it is a habitual session. Well, it applies, so if you got any of those, you got it right. All right, how do I go to the next one?
I think they're down. Yep, to the left. There's like a little. Where the one in. Oh, right there.
Thanks. All right, real quick, go with your first one. All right, good. Hyperemesis syndrome. Okay, so we talked about that, the weight loss, persistent nausea, vomiting. An example of high-risk behavior when combining two synergistic illicit substances. We didn't talk about this. All right, synergistic. So these are two substances that together cause increased symptoms. Okay, so synergistic meaning, so when we talked about stimulants and depressants, right? So this would be correct. So opioids are depressants as well as alcohol. So together, when used together, so that would be considered a high-risk behavior. So if you're asking your patient and you're screening, have you combined more than one substance? And they say yes. So that would increase their risk of high-risk behaviors of overdose. Okay, so in your brief intervention and the start method, you are focusing on that and making sure they know not to combine substances, right? So energy drinks and alcohol, this is more like a stimulant. That is more a depressant. Heroin is a depressant, and opioid, cocaine is a stimulant, right? So they're not synergistic. So, preventing relapse, this is something else we didn't talk about, but for a patient about who's in recovery, and you want to keep them in recovery, right? Having unstructured time is not good. You want structure, you want a plan, you want, so there's less time to think about using that substance. The old network's probably not a good idea because they might have some people who might be enablers. Preventing fatigue. So getting good sleep is important for patients who are recovering. Suppressing feelings is not a good thing. You want them to be able to talk about it, right? So you'll notice that often when, people who are very open about their addiction are in a good place because they, probably not 100%, but they're able to talk about it, and it's a good sign. So expression of feelings is going to help prevent relapse. A couple more. Good. So, it's not for substance abuse prevention, it is for detox, okay? So instead of taking an opioid, you are, so how many hours would you wait? 24 hours, you would start on Suboxone. Suboxone is an opioid, but it's going to go into those receptors and fulfill that need, right? You can. And then you'll see that.
And then how much also.
That's right. Pardon? So this is a standalone treatment, but there are also other medications, just the clonidine, the nurse practitioner mentioned clonidine, and then treatment for things like dementia, this ondansetron or Zofran, that can be used with Suboxone or methadone or standalone treatment for opioid. So you're not going to start your Suboxone. You need to wait at least 12 to 24 hours before you would start on Suboxone. So your last opioid use would need to be prior.
Wouldn't Suboxone on that treatment be considered substance abuse prevention? Because that's part of the harm reduction portion of it.
When I think of substance abuse prevention, I think of somebody who is not on any substances, and you're trying to, prevent them from starting substances. So the most appropriate answer is for opioid detox. You're trying to get them off of the opioid and on this alternate.
It's just great, because I think at some point they are close, but then you want them to prevent relapse.
Right.
So they stay on.
Let's go to the next one.
I know.
So, you have to just type something in. I gave more time. All right, so nausea, insomnia, and headaches are the most common side effects of Suboxone.
I wrote your
So these are, I didn't bring that up, we didn't talk about it, so that's important to know. So side effects of Suboxone, that a recovering patient should be aware of nausea, headaches, and insomnia. Okay, so. All right, one last one. Or, sorry, naloxone, okay? You've got the pinpoint pupils, you've got somebody with decreased LOC, respirations less than 10, and, so you know, you're gonna give them that's the first thing. So all of these other things are not gonna be affected until your first diet. So somebody said after MD notification, so so you have that patient in front of you, the patient's gonna be treated, you want to treat them immediately, okay? You go to notify the doctor, that could take, you know, time away, and the patient's gonna pass, so really important to get the naloxone on board, to act as that antagonist. All right, good job. All right. Any other questions? You can email me if you have any specific questions. Pardon? And Kara, here, coming in to talk about a resource for you all.
Yeah, so I have an exciting announcement. It looks like there are maybe like a few of you that aren't here. So feel free to share this with the rest of the class. I will send an email. So the program is going to be paying for you to have a 3-day NCLEX prep live review with ATI, which is amazing. Where I used to work, we did this. It is fantastic, okay? So you're gonna get quite a few things as part of this 3-day live review. There are 3 dates right now that are tentatively scheduled. ACI is waiting to see if they have to find an educator to come to campus. So it will be either, my old memory, sorry, May 14th, 15th, and 16th, or May 15th, 16th, and 17th. It's 8 hours a day for 3 days.
When you have to come in person?
You have to come in person. So there's a couple of things that will help with that. Like, give you a little more patience. ATI is something called, I'm gonna read it before I screw it up, a live review guarantee. So what that means is, if you come for the 3 days, which you should, because it's being paid for, okay? There is zero reason not to come and do this. I used to actually drive students with food. So, if you then, you really don't want me to cook it, no problem. Then, if you come for the 3 days, you're here for the 3 days, you then take the NCLEX. If, God forbid, you do not pass the NCLEX for some reason, you notify ATI that you have not passed. ATI then works with you as an individual to get you past the NCLEX, okay? But in order to get that benefit, you have to come to the 3 days. The other thing you're gonna get is a comprehensive review book. You're also going to get access to something called Board Vitals. I think you're going to get access to it after the 3 days is done. I will check on that. But Board Vitals is basically a huge question bank. It's like 3,700 questions. So for those of you who are like, oh, I'm gonna buy UWorld, or you do not have to do that. You will have access to a 3,700 question bank that you will be able to set up study quizzes and or like test quizzes. So you'll get more information on that as well. But my take-home message is, come to this. This is amazing. Your fees are not paying for this. You did not pay for this. The program is paying for it, okay? So this is increased pass rates. If you compare pass rates for students who have taken this compared to pass rates for students who aren't, the ones who have taken it, the pass rates are much, much higher. ATI's bread and butter is to getting students to pass the NCLEX, okay? Any questions? I may not know.
What if you don't go to like 2 days to go?
Yeah, be here for 30. Okay. I don't have the hours, it's usually like 8 hours from morning till like say 8 to whatever 8 hours is after that, yeah.
Oh, I thought you were talking to somebody else. Is it in this room or will it be?
We don't have that booked yet, but my guess is it will be this room. This literally just happened on Friday, so that's why I have late shape putting information about it.
Can you just repeat the dates again? 14, 15, or 16?
14, 15, 16, or 15. So the idea is you guys will have your final, right, your focus should be in the final, passing the class, all that good stuff. You'll have a couple of days, then you come through the NCLEX review. Because historically, what happens is people get married, they have babies, they go on vacation, because they're like, yay, I passed nursing school. So you will now get my spiel about this too. Do not wait to take the NCLEX. If you wait to take the NCLEX until September, you will have spent the entire equivalent of a semester out of school. You need to get it booked as quickly as you can based on when you get your la-di-da-di test date thing from Pearson. But anyway. you have
And use
to
your
know what to
HCI
do.
comprehensive predictor score, it'll give you an idea of how much time you're gonna need to spend. Like, if your predictor score shows 90% or higher of passing, yes, do take it right away, if that's what you'd like to do, but if not, you wanna spend time studying.
Yeah, but this will help that too. This will help that a lot. So.
There's a sign-in sheet coming around.
If you do the full 3 days, you'll get these guys live review guarantee, meaning if you don't pass them the first time, they will work with you until you pass it, okay? And then you'll get access to this thing called Word Vitals, and you'll get the NCLEX, the comprehensive live review book to help you too. And I will send all this information via email. I just wanted to come and tell you guys and give you the tentative dates, because I know everybody works and has kids and has a life and all that good stuff. So it's very exciting. Very exciting.
Thank you.
So,
Thank you.